Добрый день. Hello.
Dear friends, good day, bonjour, hello. My name is Anton Basenko and I'm a program manager of the EATG, coordinating the Quality of Life program, and I'm glad to welcome you at the European regional webinar, You equals you and I can do more, an exploration of what we can do more to get the message across. EATG for the first time moderates a webinar in Russian because most of the registered participants come from the Russian-speaking countries and they speak Russian. That's the first experience of this kind. For that, we have a beautiful team of interpreters. And for this webinar to be available in such a broad format, we must thank our partners from Source Project 2.0 and Alliance for Public Health. And also I need to note the financial support from the Global Fund to fight AIDS, tuberculosis and malaria. As at any online event, there are certain rules that we need to voice. The next slide, please. So this event has been recorded. Please make sure that during a presentation, your sound is muted, your microphone is muted, and you can make any comments you want in the chat. Please follow this rule. We will have a separate session for Q&A after all the speakers, and if you want to ask something about the content of presentation, you just need to raise your hand using the raise hand function. If you have any technical problems, please write to us. You see the email on the screen right now. So the European AIDS treatment group is one of the oldest patient organizations. It works since 1992. We are getting 30 this year. We are supporting and defending the rights and interests of people living with HIV and comorbidities, as well as key populations affected by those diseases in the European region. EATG represents more than 2 million people living with HIV in the European region. Even though the progress in this European region of the WHO in the recent decades has been very observable, and you know, this 90 or rather 95 cascade. As of 2020, we have 70 people who know about this status. 85 received the treatment and 95 of those achieve viral suppression. But the progress is not like homogeneous in our region. And a lot of cases come from Eastern Europe. For example, only 57% of new cases come from Russia, 15% come from Ukraine. And according to different assessments, there are 2.6 million people living with HIV in the region, but 600,000 of them are not aware about their status. For all those people, there are different issues with achieving the with accessing the treatment, ensuring adherence to treatment, and stigma and discrimination are a well-known problem for them. According to the guidelines of EATG, EATG signed in 2016 a consensus statement, meaning that undetected does not mean not spread. And it says that a person receiving a treatment with full viral suppression cannot spread HIV. But there are gaps in the knowledge and understanding of this formula. U equals U in treatment not linked with HIV. And to raise the awareness, to ensure better understanding of the concept of U equals U, EATG made a mapping initiative to learn more about the initiatives of awareness in different organizations and services providing help with HIV in 4 ECA countries, Russia, Belarus, Ukraine, and Kazakhstan. So at our webinar, we would like to sort of discuss the secret formula to explain why people don't know much about it yet, why it's so important for people living with HIV, their families, their friends, for public health. And what else can we do together? What can be done more to better deliver this message in our regions, in our countries, in the region? And for that, we have a fantastic team of speakers. And to make this formula, the secret formula, U equals U, real face, and make those letters sort of alive, I'm giving the floor to Bruce Richmond, a legend, a legend. He is an executive director of Prevention Access. He's from the US, from Washington, DC. This company has united researchers and activists to make U equals U a global movement for human rights. He was diagnosed with HIV in 2003, and he worked then and still is working at public service for more than 25 years. Bruce, please, the floor is yours.
Thank you so much. Can you hear me okay?
Yes.
Excellent, excellent. And and is my screen available? Okay, excellent. Well, first, I just want to say thank you so much for inviting me here today. EATG has been a pioneer on U equals U. The mapping project that you're going to be seeing later is brilliant and is so needed in the regions, the EECA regions, as well as around the world. So we're thrilled about working with EATG, and I'm just grateful to be here today to share the U equals U background with you in a Pecha Kucha style-ish presentation. Just some background. I was diagnosed with HIV just about 20 years ago, and I was fortunate, like I am now, to be in a place of privilege where I have access to treatment and food security and housing and mental health support that has enabled me to get to and achieve an undetectable status. We need to make sure that our celebration includes everyone living with HIV to ensure that all people have the option to get to U equals U if they choose. So 20 years ago, I was in a good place to be diagnosed with HIV because I had treatment, but I didn't care about treatment. I didn't care about my life. I felt dirty, infectious. I didn't want to start treatment. I was closeted about my status, and everything changed about 10 years later with this guy. So this guy on the left was my doctor. And just about 10 years ago in 2012, he told me about U equals U. And so this was really where my U equals U journey began. He told me that I didn't need to worry, a condom had broken. I was terrified about passing on HIV to somebody. I had been so withdrawn that I didn't allow myself to love anyone. And he said, you don't need to worry, it's impossible. The medications that you're taking every day prevent you from passing on HIV. I said, could you put that in writing? I'm a lawyer, of course, I wanted that in writing. And he said, no, but I'll tell anybody that you go to. So he said, okay, I will introduce you to this field. He told me about the Swiss statement. I went to the top researchers and said, hey, can we create a statement that will confirm U equals U is true? And our goal would be to get folks to sign on and to join us in confirming what we knew was true. So we took that statement and then the voices of people with HIV demanding that people tell us about U equals U. And our idea was to go out and recruit influential institutions to sign on to this campaign. Our main target was the US CDC. So this was quite a feat in order to target an institution. But the reason that we were, I think, as a community so successful is because we united across every race, every background that would often divide us. I need to pause for a second because this is fast forwarding too fast without me having control of it. So let me okay, well, hopefully this will just stop doing this, but I apologize. So the idea was to get the CDC to update their messaging around U equals U. So we came together with activists around the world. We protested at IAS in 2017, and then things started to just really develop around the world. We started to see people rise up from every continent demanding that we be told the truth about our bodies, about the benefits of medication, just the benefits, the pros and cons, a way that we could reclaim our lives, reclaim our social lives, our sex lives, our reproductive lives, a way to reduce stigma, a way to increase people's willingness to go on treatment and access to treatment. So we started to see these campaigns forming around the world. On the left was Guatemala City in Guatemala, one of the earliest campaigns. On the right was in Auckland, New Zealand, marching with the Prime Minister of New Zealand in the U equals U march. This was a very large demonstration in Montreal with ACCM. And in Kampala, Uganda, activists have been incredible on social media, taking to the streets, rising up and demanding that U equals U be shared. And most recently, there was actually a meme from the Uganda Health Ministry on U equals U for Valentine's Day. So the activists in Uganda have been incredibly successful. This is a nursing program in Kazakhstan. Nurses went out in the freezing cold snow to make a human H equals H. And there have been conferences now around the world just on U equals U. So this is in, on the left is in China, was a PrEP and a U equals U conference. In the middle was a Russian conference with Alex Schneider, who I know folks know. And on the far right is something called the Africa Forum, which is a large continent-wide forum that's started in Botswana, Uganda, and South Africa. Series of trainings for ambassadors and pushing governments to accept U equals U. So we've got these groundswell of activist movements around the world, and we've got people in high places talking about U equals U now, which is really, really fortunate. Dr. Anthony Fauci took the stage at the US Conference on AIDS in 2017 and told a US forum that the science really does verify and validate U equals U. And then a year later, Dr. Allison Rogers, who is the lead author of the partner studies, took the stage in 2018 at the World AIDS Conference and said she said that the time for excuses is over. It's very, very clear. The risk is zero. We really need to promote this. The time for excuses is over. That was a real turning point in the campaign. And now we have entire governments that have U equals U programs. So we've got, the health ministries of Italy, thanks to the incredible Italian activists, have signed on to I equals I. In England, and in Brazil, in the United States, Canada was the first country to sign on, and Japan has integrated U equals U into their country guidelines. So the tremendous movement on a national scale to integrate into guidelines. But then we're also seeing countries go even further to integrate U equals U into policies, programs, communications. And I think those are really exemplified the best in 3 countries at this point. Zambia has a nationwide U=U or S=S program in the local dialect. This is the president of Zambia on the left-hand side, wearing a U=U t-shirt, signing on and launching their U=U national campaign in 2019. And then on the far top right is a program in Kenya. This was just recently launched with PAC Kenya with the government. And then on the bottom is the first national program ever called K=K in Vietnam, which is this brilliant comprehensive program. All of these campaigns were spearheaded by the CDC, PEPFAR, and local organizations, Positive People with HIV networks. These are brilliant model programs that many other parts of the world, including my country, could really learn from and emulate in order to get U=U to be something that is accepted, integrated into policies, into clinical work, into communication nationwide. We're also seeing now the impact of U=U. So folks might know about a recent study in South Africa that showed when men in South Africa were informed about U=U and pre-testing outreach, they were 2 times more likely to go and get tested for HIV. So it shows that U=U reduces anxiety associated with testing for HIV. And additionally, very important results came from the Positive Perspective Waves 2 study, which now we have this association, strong associations between when people with HIV are informed by their healthcare providers about U=U, they're reporting better mental health, sexual health, overall health, greater viral suppression, adherence, and willingness to share and to share their status with others. So there's this real link between healthcare providers informing patients about U=U and those patients' health outcomes. And this is really important. We need to ensure that clinicians are sharing this with their patients. So now we're at this incredible place where U=U has been accepted. We achieved as a community, a global community, we achieved what we set out to do. U=U is accepted at the highest levels. PEPFAR, World Health Organization, CDC, Unaids, and other global entities have confirmed unequivocally U=U. And in fact, U=U is a requirement of all PEPFAR countries. It's one of 16 minimum requirements of PEPFAR. And the World Health Organization this summer unequivocally confirmed U=U in their guidelines. The CDC Global for years has created materials around U=U, U=U toolkits. So we achieved that first goal. And our second goal in terms of disseminating the information has been happening for years. But now we're at a place, the third goal, which is really, really important for the activists. Our activist community is so strong, and we have a presence in 105 countries now. There are over 1,000 organizations. Some, as you'll see in the mapping exercise, are active. Others are not so active. But there is a network now in 105 countries of organizations who have signed on to communicate U=U. So we've got at the very highest levels in the field endorsement, medical global endorsement, and the credibility. Then we've got this ground force on the ground, and we need to work together to ensure that U=U is now used in our advocacy for access to treatment, whether it's mental health counseling or harm reduction services, or all the kinds of things that people with HIV need to stay healthy and to thrive. Because now we know that when people with HIV stay healthy and we can stay undetectable and we have a quality of life where we're healthy, we're undetectable, that's also public health. This was something that Ben Collins introduced to me a couple of years ago, and he called the public health argument. And I'm really grateful for him for this frame. Now, as activists, when we demand what we need for quality of life for people with HIV, we can also show how that's a win-win for ending the epidemic. We can address the interests of policymakers to end the epidemic. and this is something I think is really important to talk about, is that so we'll go to our policymaker and say, PEPFAR, World Health Organization, the CDC, Unaids has confirmed that when people with HIV stay healthy, we don't pass on HIV. This is a tremendous benefit for us as people with HIV and for ending the epidemic. It's a win-win personal health and public health argument. And this is the way, yes?
Брюс, мы немножко перебираем по времени.
Oh,
We are a
1 minute.
little bit over time, Bruce.
Oh, I'm sorry.
If you could, yeah, try to wrap it up in like 1 minute.
Okay, great. So that was actually it. If we can use this in our advocacy, I think we'll have a tremendous strengthened way of helping people get the care and the treatment that they need to thrive and to experience U equals U. So thank you so much, and look forward to seeing you in the questions.
Спасибо огромное, Брюс.
Thanks a lot, Bruce. I can say just one thing. Personally, I am proud that we had an opportunity to get acquainted in London recently at the European Conference Acts and listen to each other's stories at our community site. And so thank you, Bruce. And now we can actually talk about the report and the case study about the mapping of the initiatives and the situation where the U equals U in 4 EECA countries. So I would like to give the floor to William Gomes. He is today in Portugal. He's a consultant of EATG, and we are thankful for all the work that William did when preparing this report and doing the research. So William has a master's degree in migration, and he is also a member of European AIDS Treatment Group. So over to you, William. You can start, and please follow the time.
So hello, everyone. Dobry dzień всем. Hope everyone is well and healthy. Before I start my presentation, I would like to thank you, Bruce, for the great presentation and show how important it is to talk about U equals U. Also would like to thank you, EATG, to let me get involved in this initiative. Also Rocco for the great teamwork. And thank you, Lilia, Bruce, Isel, Oksana, Anton, Brian, and all EATG members and colleagues that support this mapping activity. Next slide, please. So the mapping activity took place from 11th of October last year and 13th of December. We had this challenge to map in different countries U equals U awareness activities promoted by HIV care services that aim to overcome the lack of knowledge and promote awareness and a better understanding of U equals U. Due to the short time that we had for this activity, we just focused on the activities promoted by HIV organizations and not those activities promoted by a state institution or private sector. Next slide, please. Thank you. So the mapping activity was divided like in 3 phases. So the first one, we tried to select the geographic area and the countries to be mapped. Then they map all the HIV community organizations based in the selected country. And then we try to identify the activities on U equals U. Next slide, please. Thank you. In the first phase, we selected the geographic area, as already mentioned before. So we use 5 different criteria to select the countries. So countries that was part of ICA region, the area that EATG has been working mostly and has also your members. Countries with the highest number of HIV diagnosed and the information we got from the HIV/AIDS surveillance in Europe 2020. We also then try to gather the countries connected with the land border that speak a common language, even if it's not the official one, and have already implemented activities on U equals U. Due to the limited time available for the mapping activity, the numbers of targets group was limited to 4, according to the criteria that was mentioned before. And the selected countries were like Russia Federation, the country with the highest number of new HIV diagnosed in 2019, then followed by Ukraine, Kazakhstan, and Belarus. So then we focus the mapping on those 4 countries. Next slide, please. Thank you. So in the phase 2, we aim to map all the HIV community organizations based in the selected country to later try to reach all of them and try to find out who already implemented activities on EuroClose or not. To map all the organizations working in the HIV area in the 4 countries, we used as a base the map already available on Life4Me Plus website and the Prevention Access website. So they have a mapping with a list of the organizations, and we used this as a base to create the list. But we also got support from EATG members and some other organizations to support us identify all the organizations in the country. With that, so we mapped 234 organizations, 130 in Russia, 82 in Ukraine, 11 in Kazakhstan, and 4 in Belarus. Next slide, please. Yes, thank you very much. So after mapping all the organizations, so we set up different strategy to identify activities on EuroClose. So we sent a survey that was available for 10 days in last November. The survey did not just aim to identify who implemented activities on EuroClose, but also try to get the perspective of the participants about the knowledge that key groups have about EuroClose. Unfortunately, due to the limited time that we had to make the mapping, we just got 23 answers from the survey, and 18 of them already implemented activities on EuroClose, and 5 said that they did not implement it. To compensate the low number of response, we contacted key organizations, EATG members. We also talked with Life4Me Plus, we also talked with Prevention Access and some other organizations, and we made online research to identify more activities. So combining all the strategies used to collect information, we identified 32 activities on EuroClose, but not all of them are available online. Next slide, please. Thank you. So just to give overview, so 234 organizations were mapped and 32 activities on EuroClose were identified during the mapping exercise. So it was 14 from Russia, 9 from Ukraine, 5 from Kazakhstan, and 4 from Belarus. Next slide, please. Thank you. As I mentioned before, the survey also tried to identify from the perspective of the participant the level of knowledge that different groups have of EuroClose. And as a result, we can see that healthcare professionals working with people living with HIV, people who use drugs, and the general public has extremely poor knowledge on EuroClose, and people living with HIV has average knowledge, and people working in the HIV/AIDS related organization have a good knowledge on EuroClose. Even if this perspective is not representative, can at least give us an idea of what we could, where we could start working to increase the knowledge in some key groups. Next slide, please. Thank you. And this slide can give us an idea of how the activities were implemented. As we can see here, the activities were implemented mainly online, and the HIV organizations was promoting campaigns, producing informative materials, and capacity sessions. The targeting groups was mainly people living with HIV, LGBTQI+ communities, and the general public, and worked in partnership mainly with people living with HIV organizations, HIV clinics, and local organizations. The activities were funded by foundations, NGOs, but even some of them had no funding at all. Next slide, please. Oh, thank you. So according to the challenges faced by the organizations to implement the activities, the stigma, lack of information, and lack of funding were the main reasons. About stigma and lack of information, as we can see here, things now are getting better, but in the beginning, the organizations that try to promote U have faced some challenges. And Lilia will talk more about this later with more details. Next slide, please. From the 32 identified activities on U, just 20 are available online. So on this slide, we can see some examples of implemented activities by country, like some videos, website with information about what is U campaign, like questions and answers about U, but also some more clinical information and also information about the studies that was made for us to get in this U. All the activities available online can be found on the Excel document with the list of organizations that were mapped. So we made an Excel, we put all the organizations, we also identified who did and who did not implemented activities on U, and those who implemented activities, if they had a link available, we also put the link there. So this document can be updated every time that we identified new activities. So then everyone that wants to identify which activities was made in the country, they can just access this document, select the country and see who implemented and who didn't not implemented activities. And those who implemented, then you can access the link to see the information if the link is available. So as I mentioned before, some organizations report they did promote U, but did not share the content. As a good practice, we have here the campaign promoted by Life from IPLAS in ECA region. And after this presentation, Lilia for sure will provide more information about this campaign. It's very interesting, work very closely with local organizations, and was very interesting to learn more about this during this mapping activity with Lilia. So thank you very much, Lilia, for all the support. Next slide, please. Thank you. Limitations and challenges. So during this mapping exercise, we faced different challenges, but for us, time was the biggest enemy. Sorry, if we had like more time, the survey could be available longer, and for sure we could then try to arrange more online meetings with local organizations, reinforce more the survey participation, and identify more activities that was implemented but is not available online. Next slide, please. So then if we think if this activity make any difference in knowledge, these questions can help us to think a little bit about it. My opinion might be a little bit suspicious because I worked in the map, but I would say yes, because the UCL mapping activity can support us to set up a strategy and to think where we can start work and how we can start working, with who we can start working: Belarus, Kazakhstan, Russia, and Ukraine. For this, so we set up some recommendations. Next slide, please. Thank you. So we divide the recommendations in 6 different points that EATG and other organizations can work to support the mapping countries to promote U. I also like to thank you, Prevention Access, Bruce, that is here today, that supported us with the recommendations. And on the advocacy, the first one Bruce already mentioned. So to integrate U in official HIV treatment prevention guidelines. As Bruce already said, some countries already have it, like Vietnam, USA, Japan, Canada, Zambia, Brazil, and also South Africa. Another advocacy is connected with funding. So fund more activities on U for the organizations that want to work in the topic. It is very important. The second one, education, to provide training and capacity building to building on U for HIV and on HIV related services. About the partnership, to develop partnership with organizations that have already implemented activities on EUCOSU, and also with organizations that can provide funding or at least support local organizations to get funding to promote activities on EUCOSU. About the communication, to increase the promotion of EUCOSU in different levels and different areas, as we could see around the during the mapping exercise. The activities were concentrated mainly in the big cities, and it would be great if we could see local organizations in the countryside also promoting EUCOSU. So translate, then the Technical and Transmittable Strategy toolkit that was produced by Prevention Access into Russian, but also into Ukrainian and other languages. And this document was designed to help build the capacity and skill to promote EUCOSU. And about the online repository, to create an online repository or to promote the existing one, where the organizations can share their experience, their activities, but also find partnerships to join activities and use the materials that are already available. With this recommendation, I finish.
William, 1 minuta.
Yeah, I will finish now. So with this
1 minute.
Yeah, with these recommendations, I finish my presentation. Thank you very much, everyone. Спасибо большое, and I'm also then available for questions. Thank you very much.
Thanks a lot, William. I'd like to tell this now to the participants. You have a unique opportunity because this report is still open for your comments, and it will remain open for some time yet. So you can provide your comments right now in the chat or later to our email. Now we are moving to our context, country context. But let us start also with the regional scope with the ECA region, and I'd like to give the floor to Lilia Ten, Executive Director and Chief Editor of Life for Me Plus for fight with HIV, tuberculosis and hepatitis. She's been working at the different LGBT HIV organizations, starting in Kyrgyzstan. She comes from Kyrgyzstan, and now she works internationally. She writes articles to raise awareness about HIV, conducts anti-stigma campaigns, and does things to improve the quality of lives of people living with HIV, and also motto is move forward even if you don't see the result. Yes, thank you very much, Anton, for this great introduction. And I don't have an opportunity to share my screen, unfortunately. Yeah, unless the moderator does it for me. Well, first of all, I'd like to thank you for the opportunity to speak in Russian. I know that for EATG, it's the first experience of this kind. Why I would like to speak Russian? Well, because we speak about the ECA region, and many participants, they are Russian speakers. Well, first of all, I'd like to say a few words about the Life for Me Plus. We are not a commercial organization, a patient organization. We work at the international level in a number of countries. We are represented in 15 languages. We work in the area of e-health. We have Life for Me Plus mobile app. It's accessible in more than 100 countries, specifically designed for people living with HIV. And we work also to improve the awareness, raise the awareness of the society, of the people on HIV, tuberculosis, hepatitis, and so on. Today, I'm going to tell you about one of the campaigns we initiated. It's U=U, and we occasionally conduct such campaigns. And I see Anton has this T-shirt with no HIV stigma and respect my HIV. These are also campaigns. Maybe you were in London in autumn last year when we conducted this campaign. You could join it and get that too. Now, talking about U equals U, in 2017, Life for Me Plus initiated Russian speaking campaign in the ICA region. We translated all the materials available back then, statements, studies, because the first thing people asked us, is it really true? Does U really equal U? So we prepared all the materials for people to have no doubts about that. And this is the site that we launched in 2017. Any person could join the campaign by simply taking a photo with one of these beautiful posters and posting it in the social media with U equals U hashtag. So we were supported in Georgia, Moldova, Kazakhstan, Ukraine. We promoted this agenda among the experts. It was in St. Petersburg at the forum in 2017. I am sure you know a lot of these people. Unaids also supported us. And in fact, throughout the campaign, if we look at it, at the beginning, the statement Bruce mentioned was signed by 62 organizations. It's 13 out of 14 ICA countries. I will not be speaking about where they more or less, but out of 62 organizations, 11 organizations are state governmental organizations. They are mostly AIDS centers. People from outside Europe don't know, but in ICA region we have specialized state clinics called AIDS centers. And for us, it was very important that some of the AIDS center from certain countries were very active about our campaign from the very beginning. So the active phase at the beginning passed, and then we had to encounter a lot of barriers. Some of them have already been mentioned today. People, of course, were afraid, and the community members were afraid, and they did not believe. And the main task that we had was to provide all these evidence-based data, all those studies to prove them that there is no risk. And the second barrier that we encountered was about the health professionals, because they also have their doubts, and they saw big risk about that. The risk that people living with HIV stop using safety measures, and then we will have a huge increase in incidents. And they said, they were telling us, don't promote U equals U because people will stop taking care. We had to make a lot of efforts, and many people know about U equals U now, but not sufficiently many. And like Bruce said, for us to move on, to include this point in the guidelines, we need to get to the next stage to speak about that at the national level, at the level of government. In 2021, it was 5 years of U equals U, and we updated all the information, including the scientific evidence. We keep speaking at all the platforms about U equals U. This is the 6th St. Petersburg Forum. We had another session on U equals U. It was it was a presentation by Dr. Stepanova, and she presented the study of how U equals U affects the lives of people living with HIV. We wanted to deliver this message to doctors because it was about health and science. In 2021, it was for the first time that in Russia they spoke officially about U equals U in the Russian Federation. I don't know how important that may be for other countries, but for Russia it was very significant. And I hope that in 2022 we will have success about that, because we keep doing this work, and in 2022 we are going to launch a week of U equals U, similar to the European week of testing. Don't speak about this occasionally, but speak about it for a week. And that's all I wanted to say. If you have any questions, please. Yeah, that's it for me. I'm happy to take part in the discussion and answer your questions.
Thank you, Lilia, for for taking us on this trip to the region. And now we have other colleagues, so please, you all have 5 to 7 minutes so that we can keep up with the timing. And as we see from the report and from Lilia's presentation, of course, the driver of U equals U. Like we can see that most organizations who work in this area, they are CSOs and they are the driver. But we all understand how critically important is cooperation of CSOs and government sector, especially in the context of building policies, not just one-time participation or support of some campaigns or messages, but building policies by the ministries and departments and agencies engaged. So now we are landing in Ukraine, and I'm happy to give the floor to Anna Koval, who is the chief specialist of HIV area from the public health center in Ukraine. So she has been working with the Public Health Center of Ukraine since June 2021, and her main activities are PrEP equals U. So over to you.
And if it's possible, yes, so I can share the screen now. Thank you everyone for being here today, and also I would like to thank the European AIDS Treatment Group for this invitation. It's a big pleasure for me to participate from Public Health Center of Ukraine, of the Ministry of Health of Ukraine, and talk today about the implementation of our undetectable and transmittable strategy. First of all, I would like to say that as a national governmental organization, Public Health Center coordinate all HIV programs in our country, and due to our national HIV strategy 95-95-95 by 2030 to eliminate HIV infection, Ukraine step by step works and going. I'm sorry, there is my colleague showed that there is no second slide, right? Can you see the slide now? Yes? Okay, thank you. So Ukraine step by step is working to implement our strategy. And as you can see on this slide, even the pandemic times, during the pandemic, our national goal is still on the way, and we even really succeeded for now with data of people living with HIV who receive Unaids level of viral load. Our main ways which we are moving on due to our goal is decentralization of antiretroviral therapy for everyone who might need it, optimization the treatment regimes, because for now we have a huge amount of people who are getting HIV with Altegravir and Tenofovir. Also, we increase our rapid and start system, and also by daily work, we systematically search for lost patients who started to use ART and stop it in some cases. And also strengthening of testing and prevention goals are our up-to-date goals for today, because testing, not also testing population by new HIV cases, to give these people treatment, people who have a high risk of HIV infected, to give them some different prevention programs. And as you can see, we are really increasing our pre-exposure prophylaxis program in Ukraine. But also there is the understanding that people in Ukraine need to have really truthful information to understand what the undetectable, untransmittable scam is and what should they do with that. That's why in 2020, the Public Health Center developed the informational campaign for everyone. We have the informational page where you can find any information about HIV, about antiretroviral therapy, about this scam, undetectable and transmittable. We have a national branding, different promotional videos, targeted advertising, and also we do different info companies for not for only for K populations, but also for general population to increase the information around the people. And still for today, we have a lot of plans. We have still a lot of work to do to bring the people the information to make their lives with HIV much more better. That's why we see our trends and regulate updating of our national standards, optimization of different testing programs, ensure the sustainability of different services for people who live with HIV, strained programs aimed at minimizing separation from treatment, ensuring timely coverage of viral load, expansion of regional information campaign about undetectable, untransmittable, and PrEP and different prevention companies as well, and continuation of decentralization of antiretroviral therapy for everyone who might need it. And with these slides, I would like to thank you again, EATG, for the chance to participate today. And I would like to thank everyone who is here and listening to this webinar. And if you will have any questions, please, I'll be glad to answer. Thank you very much.
Я хочу, в свою очередь, поблагодарить вас, Анна, и
And I want to say a big thank you to you, Anna, and all the staff of the Public Health Center. Of course, as I am from Ukraine, I know many people from your team personally, and I always was impressed with the level of response and cooperation that I really see in other countries of the region. And your support of CSOs and community organizations. So please continue this work that you do and keeping this bar so high. And now we go to the southern Western Europe, we go to Italy. And I would like to give the floor to Lila Kasmara. So she has been working in HIV field since 1993 with an Italian NGO, Lila, the Italian League for Fighting AIDS, one of the leading national organizations. Over the years, Lila has become more and more involved in the European policies and networks. So Lila is a member of the EU HIV/AIDS, Hepatitis and Tuberculosis Civil Society Forum, which she co-chaired for the period 2012-2015, vice chair of the WHO Regional Coordinating Committee for the TB, HIV, and viral hepatitis. She's a steering committee member of the COBATEST network, has been a steering committee member of the AIDS Action Europe from 1211 to 1216, is one of the Italian focal points for the Correlation European HR network, and has been the civil society expert in a number of the WHO missions in the European region and involved in some of the ECDC advisory groups. Lila has been and still is a partner of many European projects and joint actions, and is deeply involved in the Italian projects, advocacy, and policy issues. So I would like to give the floor to Lila, and she will tell us how important it is to have consensus of this on these issues. Over to you.
Thank you. Should I share my screen, or can I?
Да.
Okay, thank you. So I'll dive into my presentation, not to lose any more time. I thank you for the invitation, and I'd like to tell you about the National Consensus Conference that we organized here in Italy. NGOs here in Italy were, of course, spreading the message about U equals U, but in 2018, we saw that here many doctors specialized in HIV treatment had not yet accepted the scientific validity of treatment as prevention and U equals U. And consequently, they were not informing people living with HIV of this evidence. So the community of CSOs and people living with HIV asked the Ministry of Health to hold a consensus conference. We wanted to ease the introduction of U equals U into current practice, and we wanted to provide HIV doctors with references and guidelines. And also we wanted to promote correct information among people living with HIV and the general population so that stigma and discrimination would be beaten. So the request from civil society was accepted, and we prepared a specific protocol that was developed for the preparation of the conference, which was held in Rome in 2019 with all the involved stakeholders. And this is the cover of the output of the initiative, which was a printed 37 pages publication, available also in PDF format, which has been widely distributed to doctors and organizations. Civil society was involved in the entire process and widely represented in all roles except for the very technical ones. The representatives of civil society are highlighted in yellow in this snapshot of the booklet. And as you can see, we were many among the chairs, among the developers, the panelists, and also the external stakeholders. So we had an important role. The chairs, in collaboration with the working group, defined the list of 9 questions needing exhaustive answers for submission to the jury panel, and the answers were subsequently elaborated into recommendations. The analysis of evidence was based on the review of documents retrieved by consulting the public PubMed databases and other databases, selecting documents published up to September 2019 in Italian, English, French, Spanish, and German, and visiting the websites of infectious diseases societies and international agencies, and also on national organizations. So I'll go through the 9 informal questions that were posed. The first one was very simple. What is the risk of transmitting HIV through unprotected sexual intercourse for people living with HIV on ARV in stable virological suppression? And here's the statement. The statements are the outcome of the expert discussions during the conference. Following the analysis of evidence. And of course, statements were adopted as the official position of the Ministry of Health after the consensus conference. So they are very important. So for this first question, the risk of transmitting HIV is equal to 0. So no risk. And you see how the recommendations were rated also in blue brackets. The risk is 0 for all modes of sexual intercourse. Treatment adherence is required. And ARV interruptions nullify the effectiveness of these conditions. Informal question number 2 was, what is the viremia threshold below which people living with HIV on ARV treatment are considered in virological suppression concerning sexual risk of HIV transmission? And the statement is the HIV viremia threshold below which people living with HIV do not transmit HIV to their negative partners through sexual intercourse is 200 copies or below. Question number 3, how long should people living with HIV on treatment be undetectable in order to be considered virologically suppressed to prevent the risk of sexual transmission of HIV? And the statement was, the condition of non-contagiousness is defined after at least 6 months from ARV initiation through documented virological suppression. If following a control with an HIV RNA value below 200 copies, people living with HIV report therapeutic interruptions, it is necessary to reconfirm virological suppression through viremia below 200 copies. Question number 4. How often should people living with HIV be monitored for the purpose of the correct evaluation of stable virological suppression? Should such periodicity vary in relation to individual characteristics and clinical situation? So the timing of virological monitoring in people living with HIV on ARV, indicated by Italian guidelines between 4 and 6 months, is adequate to support the untransmittability of HIV. Increased frequency is not required at the initial phase of ARV treatment. No indications are currently supporting more frequent clinical monitoring in people living with HIV whose viremia is below 200 copies, even in case of previous treatment failures and/or prior selection of resistant mutations. Number 5, in case of condomless sex between an HIV negative partner and an HIV positive partner on ARV with stable virological suppression, is PrEP recommended for the negative partner, including women who want to conceive naturally. PrEP is not recommended to an HIV negative individuals in case of unprotected sexual intercourse with an HIV positive partner on ARV with stable virological suppression. In heterosexual serodiscordant couples who want to conceive naturally, in the case that the HIV positive male partner is on ARV with stable virological suppression, PrEP is not recommended for the HIV negative female partner. In case of condomless intercourse with an unsteady partner or condom breakage between an HIV positive partner on stable virological suppression and a negative partner, should PEP be recommended to the negative partner? PEP is not recommended for the HIV negative partner in this case. Can people with HIV on ARV suppress viremia, transmit HIV during an occupational accident? People living HIV do not transmit HIV during an occupational accident if they are suppressed. Should PEP be recommended on HIV to HIV negative individuals in case of an occupational accident involving an HIV positive person on ARV with stable virological suppression? PEP is not recommended. Both, of course, it has to be suppressed by, for at least 6 months. Okay, and these conditions need to be implemented.
Ускорьтесь, пожалуйста.
Lela, could you please wrap up a little bit because
Yes.
we are falling out of the time.
Okay. What is the risk of transmitting HIV during basic procedures for HIV positive healthcare workers on HIV with stable virological suppression? In this case, there is no risk of HIV transmission during invasive procedure. No restriction need to be applied to healthcare workers who fulfill these conditions, and it is deemed appropriate that HIV positive healthcare workers on ARV have their viremia monitored quarterly. So this is the last slide. What happened afterwards? So the process of preparing and holding the consensus conference on U=U took a lot of time and effort to all involved. And all the statements resulting from the conference confirmed the scientific validity of the evidence. The final document was widely distributed and published on the website of relevant institutions. Nevertheless, conservative doctors and institutional representatives are still reluctant to acknowledge the scientific evidence of U=U and do not pass the message on to people living with HIV and the general population. Civil society and the community, supported by many good doctors, of course, continue to advocate to spread the U=U message and make sure it reaches all. So we're still advocating, we're still going on and hoping to reach everybody. Thanks for your attention and sorry for the delay.
Все нормально, Лила.
It's
Спасибо.
okay, Lela. Thank you very much. I believe personally that consensus is something we often lack in HIV area when we speak about different stakeholders of the process, community, CSOs, public sector, academia, health professionals, and so on. So thank you very much for this great presentation. And we are moving again to Ukraine. It is important to note that the organization, the next speaker is going to present, is an international charitable foundation and works in the ICA region and is well known then. So I'm giving the floor to Olga Denisuk from the Alliance for Public Health. Olga is a doctor. She is the head of the group for optimization of the program studies by the Alliance. She has 13 years of experience working mostly with key populations. She works on activities to improve the detection of HIV, establishing the contacts, and retaining the patients in treatment. So let's move to practical things from advocacy and policy making. Let's move to practical implementation of certain interventions, allowing to actually ensure that the U equals U is used in practice.
If you allow me, yeah, just a second.
Постарайтесь вложиться до 5 минут.
I'll do my
Может быть,
best.
даже.
Try to make it within 5 minutes.
Окей.
Okay, can you see it?
Да. Спасибо.
Okay,
Yes,
thank you, dear colleagues. I will try to be quick as possible. But before we'll move to the practical aspects of program implementation, I would like to set your attention on the new Unaids targets, which are linked to 2025, which are intermediate targets before the 2030. And as you can see, we are not recommended, and we are not only focusing on the pure reach of the targets for HIV case finding or ART or undetectable viral. The concept becomes more broader, and the concept now involves many other parts of the healthcare and non-healthcare systems, which are contributing to the improvement of the cascade in general. So we can see that one of the targets is removing societal and legal impediments to the service delivery, and linking or integrating the provision of HIV services with other services which are needed by people living with HIV, and which is very important, communities at risk. This all will contribute to the goal of staying healthy and build sustainable livelihoods for the people with HIV. So when we talk of reaching the target of undetectable equals untransmissible, what do we exactly mean by that from the program perspective, and what stands behind? So from the program point of view, I would say that we should look at the interventions at different levels, and we should look on how to set the proper base, which means to put the efforts to enhance all the previous stages in treatment cascade, at HIV testing, at HIV case finding, at ART initiation, which means that we should put integrated services, person-centered approach, which includes proper implementation of the HIV self-testing, community-based ART provision, online services, which are now widely implemented and widely used, but the scale is still not enough. And of course, mobile services, meaning reaching those areas which are not reached by the current programs, remote areas, remote regions, and so on. It is very important to cover non-medical services which are related to quality of life and essential needs, because we usually focus only on the medical targets, and these essential services become a barrier, or essential needs becomes a barrier for our clients, especially those who are from the key populations, and it prevents them, and it prevents our clients from focusing on the health-seeking behaviors as well. And of course, we should be focused on the innovative models and algorithms, which again help us to improve HIV case finding, improve reaching people with HIV testing, and ease ART initiations for those who are in need of that. So what are the main challenges? What are the main challenges for reaching the target of U equals U? We see from the program perspective, again, especially for the key populations, that first three stages of the cascades, like coverage with testing, ART initiation, and again, when we move to retention and care and reaching undetectable viral loads, can be provided at the separate levels by the separate implementers. And when we evaluate the program, we would look at that and would evaluate it from the different perspective, not putting the one piece of the success. So it is important to make these services connected between each other, to make people who are in charge of implementation being at the same level, being again responsible from the beginning to the end of the cascade. So to improve the coordination between the medical and community-based services. And again, another challenge that we see, that the focus is very narrow on the medical intervention. We keep missing other needs that can contribute to reaching the target of U equals U. And I would like to share with you some practical experiences that we have from Ukraine, we have in Ukraine. So this is an example of the current program, which works for people who inject drugs and their partners. The program starts from HIV testing at outreach, and the program uses social network strategy for HIV testing that allows us to increase the HIV case finding. Everyone who were and who are identified. Okay.
Sorry, someone's got their mic on.
Every client who is identified through the optimized case finding model will be linked to ART within the same program. So we don't stop our activities at the moment of HIV case finding. And when we link our clients to ART, the involvement of the community, the involvement of the program does not stop. We continue supporting our clients, our patients for the next 12 months, during which period we allow and we aim to implement all activities to improve the health-seeking behavior and to make the person staying within the treatment programs. So the population again is people who inject drugs and their partners. Okay, I'm finishing. This is my last one, I think. And scope of services are medical and social support for HIV positive clients identified in the program, supporting development of health-seeking behavior. The important part that, again, all services are provided within the same program where people are getting tested. So we don't stop at any points of the cascade. We start from the beginning and we try to reach the end point of undetectable viral load for those who are HIV positive. We support the development of the sustainable adherence practices and, of course, to reduce risky behaviors for HIV transmission. So the duration of the adherence support intervention is 12 months, and the goal of the program is undetectable viral load, which we measure at 6 and 12 months of ART. So basically, when you look at the focus, we have an HIV positive client in the center, which is basically the patient and person-centered approach. We have a medical provider involved who works together with the social worker, and we include non-medical needs, which appears during the whole period of the social support that we provide. So what's important in this program, that we have a clear and measured targets, we have a joint responsibility, and we have the teamwork for the client, social worker, and the medical provider. And these are the previous results which we have from the last program year. We don't have all data because the viral load evaluation is still, for some patients, is still on the way. So you can see that of 100% people who are enrolled in this intervention, we have more than 80% retained. And of those who were eligible for viral load, 94%, and these are again key population, people who inject drugs, their partners, more than 90% will reach undetectable viral load at 6 months, and 96 from those who were eligible at months 12. I would like to say thank you to our donors for their recognition of the need to implement adherence interventions. These the main donor is CDC, PEPFAR, and Global Fund, and of course our partners, regional NGOs, our mobile teams, which are working directly and managed by the Alliance for Public Health, and of course healthcare facilities and medical providers. Thank you very much. I think I'm done.
Спасибо большое, Ольга. Я думаю, это прекрасный.
Thanks a lot, Olga. I think that is a great final presentation for our session, and it shows that today we have all the tools to make U equals U a reality for different people. So colleagues, now we start our Q&A session. So we are really running out of time. So we actually have 10 to 15 minutes only left. So you can raise your hands. And we actually saw 2 questions in the chat. But I think that if people raise hands, we will give them a floor first. So please raise your hands. Colleagues and organizers, please help if people raise hands. Let's give them the floor.
Hello, Anton. Was a question here before asking who participated in the survey from Belarus?
Да.
I will share here in the chat the name of the organization then. Okay.
Спасибо большое. Да, я так и хотел предложить сделать.
Okay, thanks. Yeah, that is what I wanted to suggest, not to lose time, just write in the chat names of the organizations. And I think also in the report, you can see the names of organizations. Also, we have a question in chat from Elian. So what is the situation or position about U equals U and breastfeeding, and what we can say to mothers and mothers to be about U equals U? So who would like to answer this question among our speakers? Olga, Bruce, Anna.
Well, I can say that the.
So, if I may, from the latest conferences and discussions around this topic, we can see that it is unclear if we can see U equals U with regard to breastfeeding, because the data is really scarce. And if there is the slightest, even the minimum risk, so healthcare workers always say that better don't do it. So of course they try to prevent any negative outcomes. That is the position of doctors and researchers. But I think that breastfeeding is actually quite a complex and complicated topic, and we know that recommendations differ depending on the country, because first they look at what is better for the kid. If we are talking about African countries with the low standard of life, they say that it is better to do breastfeeding because it actually allows the kid to survive, because maybe water is not available there, clean water is not available, and it is the only actually a possibility for the child to survive. But in other countries, there is a prohibition on breastfeeding, irrespective U equals U, status or something, because I think that there is no single answer, because the situations in countries are different, and all the things related to children and the breastfeeding, it is closely relates to women's rights issues. So I think that every community, every country will have their own choice and their own answer to this question. Thank you, Lilia. I see Elian
Yes,
raised a hand. She actually asked this question.
I want to ask us if African women in African, because they have a low income, they can manage to breastfeed their children and they are protected, because I've seen it with my own eyes. I was I didn't manage to breastfeed when I was here in Netherlands. I'm living in Netherlands, but I'm from Burundi. And the strange thing is the mothers were told about breastfeeding, but they were never told about EATG. So some were very afraid of even having a sex, or the one who don't have partners to look for new partners. But then when it comes to this breastfeeding, there was success because they are giving and their baby were looking healthy. A question is, here in Netherlands, I know a few women who breastfeed now, since EATG is a very well known, and it was their choice, but they had a support, medical support, then meaning they have to go a couple of times to keep checkup. And what if the women in your region, they also have that wish, they are pretty confident and they are undetectable? Do they, and if they want really to take chances, can they not be supported by the doctors? That's the question. Thank you.
Хотят рискнуть в нашем регионе звучит всегда.
Well, if they want to take a risk, it actually sounds very risky in our region. So that is a question for discussion, actually. And we see another hand, Arda, of our Turkish colleague. So please, over to you.
Hi all. Hello, Bruce. Actually, I have a question for Bruce, not behind the science, not science behind campaign, but also practical things. Sometimes we have a situation that even community attacks the community, you know, about the science behind it. So, I mean, all the scientific facts are really okay, but maybe we have common strategy, or maybe you can share some your experience from your experience, because currently the body also attacked the campaign. So I'm really wondering about your experience and your offers on this.
Yeah, that's a really good point. I mean, we were, you know, change is hard. Change is humans resist change. It's understandable that any kind of shift in the narrative, like U equals U, which is going against decades of what we all thought about people with HIV, is going to be a radical mind shift. And so even folks who benefit from U equals U or believe the science sometimes have a difficulty accepting the change. And so people naturally will fight back. I also think folks sometimes feel as activists, there's a lot of territorialism. People kind of want to tear down things that are, you know, it's the tall poppy syndrome in Australia, they call it. So the way that we get around some of the resistance and the pushback around U equals U is first you need to listen. We need to listen and say, there's got to be something in what they're saying that we can understand that's of value, and how do we address the criticism? And we also know how to be selective and who to listen to, because sometimes folks are just throwing rocks, and you also need to go around. So we align with one strategy, as you know, is align with influencers, align with the people who are proactive bridge builders, and they seek to build relationships and understand each other rather than tear each other down. And there are more people in our field who want to work together and want to build and want to support the quality of life for people with HIV and to end the epidemic than those who want to tear down. Often the ones who want to tear down have a voice, but we have to just go, listen as much as we can, and then also go around and join together like we have with you, Arda, and Leila and other folks here.
Thank you,
Спасибо,
Bruce.
Брюс. Лейла, у вас дополнение к ответу Брюса?
Leila, do you have something to add to Bruce's answer, or do you have a question?
Yeah, two comments, very brief. One is echoing what Bruce said. I think that U=U has the same problem as harm reduction. People think, some conservative people think that harm reduction policies encourage drug use while we care about people's health. And the same for U=U. Some very conservative people with strict religious principles think that U=U encourages free sex or sex with many casual partners. And they do not want to spread the word. But it's just sexual health that we're talking about. And this has to be a strong statement. The other thing is for breastfeeding and U=U, in Italy, where there is a growing movement of women who want to be helped in breastfeeding, even if HIV positive and undetectable, and they want to get medical support and not be totally discouraged. And we are also bridging with some women in the US, and we want to encourage further research on this topic because we think it is important. And this is all I wanted to say. Thank you.
Лейла, спасибо огромное. Могу сказать браво.
Thank you, Leila, and I want to say bravo. With the first part of your answer, you just predicted the first part of like my next question, actually. But it is provocative a little bit because you mentioned harm reduction programs, and I, as a person representing the community of people who use drugs, I am myself for many years client and proponent of harm reduction programs, and I promote those programs in the country and in the city and in the international arena. And there were some discussions saying that U=U as part of discussion will not allow harm reduction programs to develop if we are talking about EECA region. So my question to all speakers is, do you think that U=U and harm reduction, these two concepts, are they competitive or do they strengthen each other? Who would like to respond to that? Just you can turn your sound on. Leila, Olga, Anna.
I think they're not competitive. Why should they be competitive?
Пожалуйста, Анна.
Because I wanted to start to keep the thoughts from Bruce and Leila, and when we started to think about and detectable transnational campaign, we started to search different psychological trials about changing behavior around different communities in Ukraine and in different countries as well. And we realized that for changing the behavior for people, it should come like 5, 10, or maybe 15 years to change behavior, to change their way of thinking about HIV, about ART as well. So we started to put the undetectable and untransmittable campaign as a prophylaxis campaign to give the people understanding that if you use ART, if your viral load is undetectable, you can't give the HIV to your partner, to different partners as well. So, and the second mention from the Anton is that I think we realize that U equal U program, this is a partner of different prevention programs because they have to go step by step to give the people understanding that EU equal U is normal and HIV is not the disease we need to be aware of, and there is no way and time for stigmatization. So I really think that undetectable, untransmittable formula is a partner of different programs.
Спасибо, Анна. Еще один ответ.
Thank you, Anna. One more answer from Lela, maybe, or Olga.
Just a quick comment that, as I mentioned during my presentation, I see it as a partner in targets, as a partner in goals. They don't go separately. That this is one basically process of the program.
Спасибо большое. То есть
Thank you very much. There is the community should not have problems about that. So let us know that we are at the end of our meeting. Thank you very much to all the speakers. All the presentations are going to be available to the participants. The report on mapping is still editable. You can comment on that in the chat. In the chat, you can also see the emails where you can submit your comments to the report. I'd like to say thanks to all those who have found the time and opportunity to participate, even though there was some confusion with time zones also, but I thank everyone who has been participants to our meeting. I'd like to thank all the partners. This is Project 2.0, Global Fund, Public Health Center, LELM, Prevention Access, Life for Me Plus, the Alliance for Public Health, and the interpreters who interpreted for us, Vladimir and Anna, thank you very much, as well as my colleagues, EATG, Maria Kani, Nana Roca, Adama, and so on. Everyone who has been instrumental in finally conducting this event. So I'd like to know that after this meeting stops, you will be referred to a feedback form. There are just 10 questions in English and 10 questions in Russian just below that. Choose the language you prefer. Thank you very much in advance for that, and I hope to see you at our further meetings. Thanks a lot. Have a nice day. Have a peaceful day. Thank you and goodbye.